Marvin Goldfried is a distinguished professor of psychology at Stony Brook University, where he helped to develop the graduate program in clinical psychology. He's the co-founder of the Society for the Exploration of Psychotherapy Integration. Alan Francis is a professor of psychiatry and chair emeritus at Duke, and was chair of the DSM-IV task force. Marvin describes the evolution of his psychotherapy orientation as psychodynamic, behavioral, CBT, and eventually integrative. He practices, teaches, and supervises what works clinically using direct and indirect evidence base. Alan describes his approach to psychotherapy as whatever works, or no one size fits all. He was trained and taught at the Columbia University Psychoanalytic Center, but remains equally interested in brief, supportive, cognitive, behavioral, interpersonal, and family therapies. Please enjoy this week's episode.
Good morning and welcome to Talking Therapy. I'm here with my friend and colleague, Alan Francis. Good morning, Alan.
Hey, Marvin. Good to see you.
And I'm Marvin Goldfried. So, Alan, let's talk today about a topic that I've given a lot of thought to, namely, can we do therapy without thinking? And this was the topic that I attended many years ago at the Society for Psychotherapy Research. There was a panel discussion. There were about 12 of us sitting around the table, most of us practitioners and therapy researchers. And much to my surprise, we had a consensus. Yes, you can do therapy and you can do good therapy without thinking. I think you can do crappy therapy without thinking. And I think a lot of people do crappy therapy.
And you can do crappy therapy with thinking.
And you can do crappy therapy. That's right. All kinds of ways. But what scares me most is when somebody says, well, I just had the feeling, the intuition that this was going on. And I've seen instances where that feeling and intuition was really biased. So, for example, did you have a question?
No, go ahead.
Okay. And I've mentioned this to you once before, where a graduate student of Paul Wachtel's, who was interested in psychotherapy integration, met with myself and some graduate students. And she was talking about, actually one of my students presented a case of a young woman who was traumatized and was showing symptoms of PTSD. And she was worried. One of her worries was that she was afraid her mother might die, and she was very close to her mother. And this student said, well, my intuition says that she's angry at her mother. And I said, well, what is there in the case description that would indicate that? Just nothing. It's just a feeling I have. And I found that chilling. And I've seen other instances of that as well. Some years ago, and I don't know if you know this, there were a group of us that went out to San Francisco and spent the weekend. Paul Wachtel, Hans Strupp, Morris Parloff, a lot of Barry Wolf. And we spent the weekend talking about different approaches to therapy and also watching videotapes. And I remember one person in the group who was psychodynamic made a comment and says, well, here's what I think, because such and such was said, and it was said in a certain way, and then they came to a conclusion. And I said, let's look at that again. And we rewound and we looked at it, and it wasn't there. So my concern is, yes, we can do therapy without thinking, but we can do good therapy and bad therapy. What do you
think? I think one thought that occurs to me is that in testing reliability of very descriptive symptoms, we get mixed results with people disagreeing even on obvious things like the presence of anxiety symptoms, depressive symptoms, obsessive compulsive symptoms. And these are experienced close. When you ask raters to give an opinion about things that are experienced distant, like unconscious processes, things that require intuition rather than what you can see on the surface, the reliability disappears, and people's intuitions will be even less reliable than their observations.
Why is that?
Because
What's the process, do you
the
think?
more experience distant it is, the more different people will use their own subjective feelings, how I would feel in that situation. They'll project themselves onto the situation. And every person's guess is as good as every other person's guess, because it's very, very hard to be accurate about observations of hidden behaviors, hidden motivations. It's hard enough to develop agreement on symptoms. It's virtually impossible to develop agreement on things that are more deeply embedded and not obvious on the surface. So the deeper you go into understanding, trying to understand people's motivations, the less agreement you'll get amongst different people, because they'll be projecting their own selves in the vacuum, in the Rorschach test of the uncertainty of what lies within.
You used a word that for me is a flag, red flag. You used the word deeper. And I'm not quite sure I know what the word deeper means.
Well, I guess I was using it motivationally, that people have behaviors on the surface, they have symptoms on the surface, and these are hard enough to rate.
Yeah.
But what their internal feelings, thoughts, what are the motivations that lead to those symptoms? What are the contexts that lead to it? What are the stressors that lead to those symptoms? That these are much less on the surface, much more individual to each person, much harder to get agreement on from observers, because if you can't see it, if you have to sort of intuit it, you have to feel it, you're much more likely to project yourself into the situation, and different people having different experiences will have a kind of Rashomon interpretation of what they're seeing.
Okay, so by deeper you mean inferential.
Inferential, exactly what I mean. The word I should have used.
Inferential, right. Where you see behavior X and then you infer behavior X is a result of emotion at Y or thought A, or whatever. And you're saying that
an experience is A, B, C, and D drawn from the person's past.
Right. And that the person who is making this inference is making this inference based on could be their theory, it could be their experience, it could be their reading of the literature, or some combination of those things.
Or it could be their empathy for the person, that some people are just very good at inference, and they're able somehow or other, some people are just naturally talented at this, I guess it's what we call empathy. They're naturally talented at putting themselves in the other person's shoes.
Okay, so here's the other thing too, which I think is important. I mean, let's talk about the therapist. It's the therapist's own personal experiences with behavior X and the thoughts and the emotions that go with it could be used to make an inference about what the patient might have as a thought and an emotion.
Yeah, I think that happens every minute in every session. And the question is, some people, this is formulation, some people formulate their inferences based on a very narrow pool of their own experiences,
right,
and have a hammer that they hit every nail with, even though it may be non-specific to that person. Other people are naturally gifted at somehow or other having both a wider array of experiences and emotions available to them, and greater specificity in understanding that individual, not just through the prism of their own subjective, how I would feel, but being able to put themselves in the other person's shoes. I guess we call that empathy.
Yeah, yeah.
But I'm interested in going back to that original conference where people agreed that you didn't need to think. What does that mean?
That the experience that some therapists have, or the experience and knowledge that some therapists have based on lots and lots of practice, allow them to very, very quickly make connections between behaviors, thoughts, and feelings. And it's just an immediate type of thing. And here's the key. And if you look at the in-session impact, where the person says, gee, I never thought of it. That's very interesting. Well, that explains a lot to me. then you kind of assume that that intuitive comment made by the therapist was, quote, valid or certainly effective or had some truth to it or had therapeutic impact or at least was good as opposed to bad. Here's what I always think, my metaphor. Do you play tennis or you watch tennis? Or neither?
Sometimes, yeah. I used to play a lot.
You watch a real good tennis player and it's a fast game. How do they know when to go to the net? There's no time to think. They find themselves at the net, and they put the ball away.
Yeah, there are lots of metaphors. Like boxers don't have time to parry a punch. It's too fast.
Right.
The one I like best is driving. When you begin driving, you have to think about every move, and it's nerve-wracking. And then within several months, you're driving on automatic pilot almost with your basal ganglia doing all the work, and you're not thinking about what you're doing at all.
Exactly. And then Marshall Linehan's metaphor for doing dialectical behavior therapy, DBT, it's playing jazz. For you to play good jazz, you need to know something about music. You need to be skilled. You need to have lots of practice.
Although I think that for me, at least, my view of it is that for therapy, the analogy to driving would be that some people can get behind the wheel and the drivers very quickly, they get it. Other people, me included, take a very long period of learning to be able to not be able. I have to think a lot to be able to not think about it. Mm-hmm. And I think the same way with therapy, that some people are just naturally so gifted at it that they start off not having to think very hard because they've been doing it their whole life.
Yeah.
They've been doing that kind of empathy in everything else they've done. And other people have to think very hard as therapists in order not to have to think.
Yeah. Well, that was the kind of person I was, not a natural at all. I remember reading about, okay, here's the way you do therapy. The chairs should be 45-degree angles, not too close, but not too far. Make sure that there's a pipe nearby, so every once in a while I can reach this is when it was permitted to smoke in a lot of places, because the pipe and also the pen and pencil set should match, because that will give me a sense of credibility. So this is what I thought was important in therapy. It took many, many years to find out that probably was not the essential part. But
one thing that didn't happen to you that does happen to some people is overthinking, and thinking that overthinking is a good thing. So that one of the, I think, negative things about training programs is if they imply that you have to think through everything you do, because at the beginning that may be important. Some people take that to be a lifelong technique. They're always thinking about what they're doing. It reduces your ability to feel, it reduces empathy, and it reduces flexibility because you impose a model of, I think this is what should be happening, rather than following the patient. So training programs have the danger of not just giving good thinking habits, but also giving bad overthinking habits.
Yeah, I think that's interesting. And I don't know that anybody has done a study, but this would be a beautiful study. And I'll bet you I know what the results would be. I mean, maybe not a PhD, but a good master study.
What's the study?
Okay. So you have a video of a therapist under two conditions, and the person's supposed to rate the connection they feel with the therapist. One therapist is very spontaneous. The other therapist is very thoughtful. Which relationship do you think would have a better connection? That was a question.
What do I think? I think no one size fits all.
My guess is, and somebody should do the study. My guess is the more spontaneous.
Some patients would much prefer a spontaneous therapist and will find the other person to be cold and distant and not really caring. Another patient might find, oh, that guy is always talking. He's talking off the top of his head. I want someone who thinks things through. I think there isn't going to be one size fits all.
Yes, and in an experimental situation, we call this error variance. So if you have a large enough N, You might find differences, and you'll find interactions, which of course is interesting, certainly as well. But I do think that a therapist who's very well, you know, complaints of patients who say, "Well, this therapist didn't say very much; he just listened a lot," and that is not a compliment, at least in the way it's often put.
Yeah, I guess that, as in everything else, the golden mean is better than the extreme. So I don't think either of us would want to go to a therapist or be a therapist who had to think through every detail of every moment with every session and be even more mechanical than a computer would be. On the other hand, we wouldn't want to go to a therapist who's doing everything off the top of his head impulsively. That we'd like to have a therapist who combines thoughtfulness with spontaneity and empathy.
Yes, and hopefully the therapist who is spontaneous is basing their spontaneity on knowing clinically what works, knowing the research, knowing the patient, you know, rather than just doing therapy by the seat of one's pants.
Also, I think it fits in with the idea of the corrective emotional experience, so that I think I would naturally, without thinking too hard, be much more spontaneous with people who were very obsessive and much more thoughtful with people who are very impulsive. That the therapy itself would be meant as a kind of source of identification for a different way of behaving.
Yeah.
I would try to make jokes with people who weren't funny to help them see some humor in life, but I wouldn't make jokes with a manic patient who needs to be settled down and structured. And that the session itself can be kind of a corrective emotional experience for patterns of the patient.
So there's a related thing I wanted to bring up, get your ideas on it. And that's the notion of flow, F-L-O-W, flow. I've experienced flow. I would be surprised if you did not experience flow professionally.
Maybe you should define it first.
It's kind of a hyper-focused attention on something you are doing or communicating, so that all extraneous thoughts or stimuli are shut out. It's kind of a hyper vigilance in thinking and doing. Does that resonate? Like giving a presentation, a grand rounds or whatever, that you've done many times, or that's based on lots of your experience. And you go into a mode where you're just into the topic and nothing else. You know, there are people in the room, but you're very, very focused. And
how are you relating that to the psychotherapy question?
Yeah, I'm relating it to the therapy question of doing therapy without thinking, where you say something, or at least I experienced, where I will say something. And I remember when that first started to happen more frequently. And I'd say, oh, crap. Oh, where did that come from? It was like a little bit scary. But then it hit home and it worked. So I decided to be less afraid. And it's like, okay, this is coming from somewhere inside. I'm going to go with it and not be afraid.
So it's like the click from when you're having to think about how to steer the wheel and do the brake.
How to do what?
It's sort of like back to the analogy of a car driver. Flow would be when you have a kind of gestalt click, whereas beforehand you're thinking about every move of the steering wheel.
Oh, okay, yeah.
Everything. You're worried about the braking. Whereas once it clicks and it's back into your basal ganglia, you flow. You don't even have to think about driving. You can do it. That you achieved a point in your life where you no longer had to work so hard because it came naturally to you.
Right.
Your tennis stroke got into a groove. Your tennis stroke got to a groove, and your psychotherapy got into a groove.
Yeah. Yeah, I don't know that I think of it as a click. I think of it as a result of lots of experience. And I think clinical training and therapy now is recognizing that this is a good thing in training therapists. You know, take high frequency type of therapy interactions and have them practice again and again and again how to deal with it, so that it becomes more automatic. It could be a wonderful feeling or a frightening feeling, depending on how accurate you are. I remember vividly writing a chapter in a book. And actually, I wasn't writing, I was dictating in a little hand dictating machine, walking back and forth in my office. And I don't remember writing the chapter. I just don't remember it. And then I had it typed up and edited and fixed it up. And it's like, where did that come from?
I think every therapist has to try to achieve that feeling of flow. Otherwise, the sessions will be very mechanical and inflexible and inhuman. So I think it's definitely a goal of every for every therapist in every training program. I think there's one danger with the concept of flow, though. The best sessions I've ever had with the patients who were most gifted that I've ever treated often resulted in treatments that went nowhere. Yeah. It's very possible to have a kind of false flow where each session is wonderful and there's no change.
Yes, absolutely.
The sessions become an end to themselves, and you can be seduced into thinking you're doing very good therapy because you have very good sessions, but the patient doesn't change at all in their lives.
Right. And the key word there is having a goal. What is the goal? To improve their relationships with significant others, to reduce their anxiety, to expand the kind of activities they do, whatever the goal is. And that should be where you go, rather than just understanding. Understanding is nice. Understanding is really nice. And some people, I don't think they should necessarily be dissuaded from going into therapy because, each session gives them a better understanding of themselves and they don't change. If that's what they want, if that's the goal.
I have to praise you in praise of Marvin. I think that's the perfect way of framing it. The goal of therapy shouldn't be good sessions. The goal of therapy should be that the person's life gets better and that they're able to make changes.
Did I say that?
Yeah.
I must have said it without thinking.
By themselves do not.
I must have said it without thinking.
Exactly. You were in the flow, Marvin.
I was in the flow. There's one thing I do want to bring up, which is tangential, but I think it's a valid point, and it comes from the area of philosophy of science. And good researchers, really good researchers, have what this philosopher Polanyi said. They have a tacit knowledge, and that is they know something before the experiment. They have a feeling in their bones that this is true. And it comes from, I think, undoubtedly, a sense of creativity and a style of thinking, but also knowledge. And it's very, very hard to define. And it sounds mystical. But some people have it, like Einstein.
Yeah,
I had a patient.
Like the benzene ring, quantum physics. The trouble is some people have it and they're all wrong, and it leads to conspiracy theories. So
right. Of course, that's the other side of the coin. I had a patient it blew my mind. He was a physicist, and he said he has a colleague. You ready for this one, Alan? He has a colleague who has a good feel for the universe. This is a physicist, bona fide physicist. This is not somebody with conspiracy theory or some idiot who has a good feel for the universe. I'm not quite sure what that means, except there's something about some people that are very, very unique.
Einstein could identify with the photon.
Oh.
That's empathy.
Okay, well, this is interesting. I was going to say you're very, very thoughtful about this.
Don't think too hard about it.
Okay, no bad puns. Let's just stop while we're ahead.
Okay. Bye-bye.
Talk to you next time. Bye-bye.
Bye.